Ghosh. I am an MD Radiation Oncology, and I am a consultant in Shiliguri Nursing Home Private Limited. It's in Shiliguri district, Darjeeling. So today's talk is on prostate cancer. So I would like to call upon the panelists today. So Dr. Dinesh Sinha, Associate Professor, Radiation Oncologist, State Cancer Institute, IGIMS, Patna. Dr. Jivak Bhattacharya, Radiation Oncologist, Apollo Cancer Hospital, Kolkata. Dr. Kunal Kishore, Assistant Professor, Radiation Oncology, State Cancer Institute, IGIMS, Patna. Dr. Shayun Kundu, Senior Consultant, Radiation Oncologist, Netaji Subhash Chandra Bose Cancer Hospital, Kolkata. Dr. Shraddha Raj, Assistant Professor, Radiation Oncology, State Cancer Institute, IGIMS, Patna. Dr. Shutradhar, Radiation Oncologist, Regional Cancer Center, Agartala. Dr. Rubu Sunku, Radiation Oncologist, Dr. B. Borua Cancer Institute, Guwahati, Assam. Dr. Jumi Borgohai, Radiation Oncologist, Nechri Northeast Cancer Hospital and Research Institute, Guwahati, Assam. So are you all there?
Yes, Dr. Satriji.
Please check one by one.
Okay. So
Yeah.
can we change the slides? Next one. Hello. Yeah. So prostate cancer, though it's a slow growing one, remains the third leading cause of cancer deaths in men. The next slide, can we move on to the next slide, please? So these are some of the celebrities who had been diagnosed with prostate cancer. Next one. So this is about the radiation therapy. So next one. Okay, so we will come to the today's topic. So 75-year-old diabetic male with carcinoma prostate, pT2N1M0 post-radical prostatectomy. Patient was referred for radiation therapy after 3 months of surgery. So the role of adjuvant versus salvage therapy. Next. So this is the cancer statistics of 2020 in India. So here the next one. So actually this is the number of patients of prostate cancer in 2020. So 41532 we can see. Cumulative risk been 1 in 125. Next one. Next, please. So the question is, do we have all the information required? So my first question will be to Dr. Dinesh Sinha, sir. So, sir, are you there?
Yeah, I am here.
Yeah.
So of course we should have all the information after the of pathological detail to be certain of decision making of post-op adjuvant therapy versus salvage therapy. So
yeah,
the N1 status is not very clearly defined here.
Okay. So first of all, age doesn't determine the performance status of the patient, and also the comorbidity was given as diabetes, and there are not too much information on the lymph nodes taken out. N1 is like any number of lymph nodes can be there, so it may be more than 3, it may be less than 3, and it also doesn't denote the total number of lymph nodes being taken out. And there are also missing information about the group grade margin status, which are important in determining the further treatment of this patient. So one size fits all treatment is not appropriate in node positive prostate cancer. Do you agree? And the same. So I would like to invite Dr. Jivak Bhattacharya sir to emphasize on this.
Yeah, thank you. So first of all, apart from this group grade margin status and lymph nodal status, we don't know about the PSA value for these patients also. So we don't know what was the pre-surgery PSA value and what happened after the surgery. I mean, what is the post-surgery PSA value? And and also the histopathological examination reports, though it is T2, so that means seminal vesicle is not involved, or the extracapsular extension is not there. However, margin status is absent in the report. And so based on that, we have to, when all the informations we have, then only we can comment on what will be the next step of treatment for this patient, because all this matters for taking decision for this kind of patient.
Yes, of course.
Exactly. So can we go to the next slide, please? Next one. So what factors do you think should be included in the treatment of CA prostate in case of elderly patient? So this I would like to invite Dr. Kunal Kishore sir to emphasize on.
Yeah. First of all, age and performance status of the patient is primary for treating the CA prostate in elderly patient, besides other pathological factors as positive nodes, extracapillary extensions, or any other reverse features, seminal vesicle invasion, etc.
Yeah. So can we move on to the next slide, please? So the basic important factor to be considered is treatment should not be based on chronological age, but biological age and health status of the patient. Next slide, please. So what imaging modality would we prefer to do at this stage in this kind of patient? Can I call upon Dr. Shayan Kundu? Shayanda?
So he's not there.
Okay. So can I call on Dr. Shraddha Raj? Dr. Shraddha?
Yes. Sorry, my network was a little slow in the last couple of minutes. The question that I see on the screen is, what imaging modality would you prefer? Is that the question to me?
Yeah, exactly.
Thank you. So PSMA PET, because it is specific available, I will go for that at this stage.
Okay. So can we go on to the next slide, please? So as Dr. Shraddha has already answered the question, so PSMA PET-CT is the answer to this question. So compared to conventional CT scans, gallium-68 PSMA PET-CT is more accurate for nodal staging prior to both primary and salvage lymph node dissection. A meta-analysis of the diagnostic accuracy of CT and MRI staging of pelvic lymph nodes for prostate cancer showed low sensitivity and specificity compared to that of the PSMA PET. Can we go on to the next slide, please? Next one. So I would like to invite Dr. Sutradhar here to answer this question. Dr. Sutradhar, are you there?
No, sir.
Okay, then Dr. Rubu, are you there?
Yes, I'm here.
Yeah, so can you just go ahead with this question, please?
Repeat the question, sir. Actually,
so we have a 75-year-old diabetic patient with a pT2N1M0 post-radical prostatectomy carcinoma prostate. So he has been referred for radiation therapy after 3 months of surgery. Role of adjuvant versus salvage RT we are talking about. So these are the options given to you. So what would you choose amongst these? You can choose more than one option, because the information given till now, I don't think it may be adequate to choose one. Yeah.
Sir, the thing is, information is not adequate.
Yeah.
And as far as means there's limited data on N1 T2N1 disease. So if it is higher, if there's a little bit more high risk factors is involved, then maybe we'll include some adjuvant treatment.
Yeah. So basically, we agree on giving ADT and some form of RT may be required, right? Yeah. So can we move on to the next slide, please? So this is the NCCN guideline, which suggests that radical prostatectomy plus pelvic lymph node dissection was done in some patient. And if we go on to the lymph node metastasis group, the patient in our case, so that they have mentioned as ADT is required to be given as category 1 plus minus EBRT. So can we go on to the next slide, please? So at 15 years follow-up, the clinically N0 patients who undergo radical prostatectomy but who were found to have PN1 disease were reported to have an overall cancer-specific survival and overall survival of 45% and 42% respectively. However, this is a very heterogeneous patient group, and further treatment must be individualized based on risk factors. So this is one of the study which has been shown. And next, please. So the risk factors for relapse post-radical prostatectomy and N1 disease. So patients with ISUP grade more than 2 in combination with pT3 disease and or positive surgical margins are at high risk of progression, which can be as high as 50% after 5 years. Irrespective of the PT stage, the number of removed nodes, tumor volume within the lymph nodes, and capsular perforation of the nodal metastasis are also predictors of early recurrence after radical prostatectomy for PN1 disease. Next, please. Lymph node density defined as the percentage of positive lymph nodes in relation to the total number of analyzed or removed lymph nodes of over 20% was found to be associated with poor prognosis. The number of involved lymph nodes seemed to be a major factor for predicting relapse. The threshold considered as 3 positive nodes from an extended pelvic lymph node section. However, there is no prospective data to validate this. So definite threshold value. So can we go to the next slide, please? So this is again one of the cut piece things from the NCCN. So duration of ADT, no ADT, or 6 months or 2 years are continuous. So I would like to call on Dr. Jumi Borgohain on this question. Dr. Jumi?
Yes. Yes.
Next slide, please. Oh, sorry, sir. Sorry, sir. Can you just go back to the original? Just one slide back. Yeah. So duration of ADT in this patient, what do you think, sir?
In this patient, because I think the patient is having node positive disease.
Yeah.
So I would like to go for adjuvant ADT.
Yeah. So like as it has been mentioned that ADT for PN1 disease should be immediate and continuous for positive nodes following radical prostatectomy. And this resulted in significantly improved overall survival compared to patients who received delayed ADT. Therefore, such patients should be considered for immediate LHRH agonist or LHRH antagonist or orchidectomy. So EBRT may be added later on or maybe added immediately depending upon the risk factors. So can we move on to the next slide, please? So the combination of radical prostatectomy and early adjuvant hormonal therapy in PN plus prostate cancer has been shown to achieve a 10-year cancer-specific survival rate of 80% and has been shown to significantly improve CSS and OS in prospective RCTs. Next. So the next question is, should ADT alone be advised? When to give the RT? Can I call on Dr. Dinesh sir to highlight on this? Hello.
Yeah, it was muted. So ADT alone, if in this patient, I think ADT alone should be advised. But when there is biochemical relapse, means if there is a PSA is more than 0.6, then we have to add on the salvage radiotherapy. Is my opinion.
Yes. So like US National Cancer Database study, including 8074 PN1 patients reported improved OS after ADT with EBRT, including pelvic lymph nodes versus observation and versus ADT alone in all men with single or multiple adverse pathological features. In this study, they have shown that men without any adverse pathological features did not benefit from the immediate adjuvant therapy, means adjuvant RT. So ADT is always given, but radiation therapy immediately may not be given. It depends on the other histopathological features. We will come later on.
Yeah.
So can we go to the next slide, please? So the question is basically, after giving ADT in this kind of patient, when should we give the RT? Either we give it now or we should give later. So can we go to the next slide, please? So this is basically the immediate RT, adjuvant RT. So adjuvant RT is defined as the administration of RT to post-radical prostatectomy patients at higher risk of recurrence because of adverse pathological features prior to evidence of disease recurrence, that is with an undetectable PSA. So the first PSA generally should be obtained 6 weeks to 3 months post-radical prostatectomy, though there is no definite evidence to that, but that's what we take. And adjuvant radiation therapy is usually administered within 4 to 6 months following radical prostatectomy. Generally, RT is initiated after the return of acceptable urinary control. So next slide, please. So the question about adjuvant radiotherapy is like, are we over-treating a percentage of patients? So can we go to the next slide? So this is about the salvage radiotherapy, which is defined as the administration of RT to the prostatic bed and possibly to the surrounding tissues, including lymph nodes, in a patient with a PSA recurrence after surgery, but no evidence of distant metastatic disease. Biochemical recurrence after surgery is defined as a detectable PS level of more than 0.2 nanogram per ml, with a second confirmatory level of more than 0.2, which may be done after 1 month. So this is the repetition of what Dr. Shayon had emphasized earlier on his talk. So we have to start early. So whenever we plan for the salvage RT, we need to start early. So PSA level more than 2.2 should be enough to guide us through the salvage part. So can we go to the next? Next. So the prognostic variables to guide management include the number of positive lymph nodes, Gleason score, T stage, and margin status. And as Dr. Jivak has already emphasized on the pre-surgery PSA and also the post-surgery PSA. So database and retrospective reviews of PN1 patients reported poorer prostate cancer specific survival and OS associated with involved lymph nodes, Gleason score 8, positive margins, and pT3 disease. 15% nodes are found to be positive in post-radical prostatectomy patients who were clinically node negative. So can we go to the next slide, please? So the data basically coming from the trials which would answer the debate between the salvage radiotherapy and the adjuvant radiotherapy are given here. So the Radicals trial, the RAVES trial, the GETU AFU17, and the artistic meta-analysis, which includes all the above 3 trials. Can we go to the next slide, please? With a median follow-up between 4.9 years and 6.25 years, there was no statistical significant difference for biochemical PFS for both treatments in all the 3 trials, indicating that in the majority of patients, adjuvant irradiation should be avoided. This I am going through the artistic meta-analysis conclusions. So this is the conclusion which came out from the meta-analysis of the 3 trials. Additionally, there was a significant lower rate of more than grade 2 genitourinary side effects, late side effects, and grade 3 to 4 urethral strictures in favor of the early salvage radiotherapy. So which may also be caused by the low number of patients with PSA progression and subsequent need for early SRT at the time of analysis. Can we go to the next page? Due to the small number of patients with the combination of high-risk features included in these 3 trials, between 10 to 20% only, so adjuvant radiation therapy remains a recommended treatment option. Hello? Remains a recommended treatment option in highly selected patients with at least 2 out of 3 high-risk features. So the main thing is about adjuvant radiotherapy is like these are the high-risk features which has been concluded that if the PSA is undetectable post surgery and the high risk features are pT3, margin positive disease, and I sub grade more than 3, that is Gleason score more than equal to 8, then
Dr. Sakshi, please conclude.
Yeah, then we if 2 of these 3 factors are positive, then we should give adjuvant radiation therapy. So this is the physician should offer adjuvant RT to patients with adverse pathological findings at prostatectomy, including SBI, positive surgical margins, or ECE. So next slide, please. Next. PSA recurrence after radical prostatectomy is defined as failure of PSA to fall to undetectable levels or undetectable PSA after radical prostatectomy with a subsequent detectable PSA that increases on 2 or more determinations. Next. So what should be the RT dose? Can I ask Dr. Jibak to answer this?
Hello, yes.
Yeah.
So basically, the RT dose has been described in different scenarios. In some authors has described it differentiated between the adjuvant RT dose versus the SRT dose, with the salvage RT dose being a bit higher than the adjuvant RT dose. The ASTRO guideline recommends at least a dose of 64 to 65 gray to the postoperative region for in both scenarios. And mostly it is followed that for in the adjuvant setting, the dose is a bit lower, that is around 64 to 66 gray, while for in salvage RT, the dose is around 66 to 70 gray, to preferable to the 70 gray. So you have to keep it higher than the adjuvant setting. So I will go for this higher dose rather than this.
Yeah. So this is exactly what we wanted to hear. So in lymph node positive disease, the radiation therapy should be given to the prostatic fossa along with the lymph nodes. That's what recommended if required at all. Next slide, please. We can skip this one. So can we move on to the next slide? So the conclusion is like, so in our patient, continuous immediate ADT has to be given, whether whatever the histopathology is, whatever picture it is. But if there are more than 2 risk factors like margin positivity or Gleason grade 4 or 5, or more than equal to 3 lymph nodes involved, then we should probably go for the immediate adjuvant RT. And if the grade group is between 1 to 3 margin negative and lymph nodes are less than equal to 2 involved, then salvage RT on a PSA progression that is more than 0.2 nanogram per ml to be repeated within a month should be followed. So this is what I feel should be the conclusion. Can I just take an opinion from Dr. Kunal Kishore, sir?
Yes, sir.
Yeah. So do we agree on this?
Yes, sir. Yes, as previous panelist has correctly said that in salvage RT, higher dose of RT at 64 to 72 grays should be given. And in the high risk feature as a positive margin and Gleason grade 4 or more than 3 lymph nodes, adjuvant RT should be given. And if margin negative or Gleason grade 1 to 3 and lymph node less than 2, then salvage RT, or when PSA progression is more than 0.2 nanogram, then it should be delivered.
Okay, thank you so much. So on the next slide, please. Just a moment, please bear with us. So IMRT or proton therapy, what modality would you prefer? So again, I will ask the question to Dr. Jibak Bhattacharya, sir, please.
We have debate on this. We have debate on this in the next session.
Okay. So fine. Then we can end it here. Thank you so much. Thank you for bearing with us, and very sorry for the inconvenience initially. So I would like to thank all the panelists also. Thank you.
Thank you.
Thank you, sir. Thank you, organizers.